Hello everyone, my name is Madeline Leinenger and today I'm going to present to you my transcultural nursing theory. A little bit about myself before we get started. I was born July 13th, 1925 in Sutton, Nebraska, and I died August 10th, 2012. You're probably wondering how I'm presenting this to you if I'm dead, but I obviously recorded it before I passed away. I began my interest in nursing due to an aunt of mine who had a congenital heart disease. After I graduated high school, which was during World War II, I enrolled in the Cadet Nurse Corps to help soldiers that were wounded in the war. I received my nursing degree from St. Anthony's Hospital of Nursing in 1948 and went on to continue my education at Benedictine College and Creighton University once the war had ended. In 1954, I obtained my master's degree of science in nursing from the Catholic University of America and later enrolled in the University of Washington to complete my PhD in cultural and social anthropology in 1966. I first began developing my theory of transcultural nursing in 1955, and I published my first true transcultural nursing book called Transcultural Nursing: Concepts, Theories, and Practices in 1978. I also helped to establish the Transcultural Nursing Society and created the Journal of Transcultural Nursing in 1989. My transcultural nursing theory has three caring modules: cultural care preservation or maintenance, cultural care accommodation or negotiation, and cultural care repatterning or restructuring that are used to enhance nursing care and patient outcomes by focusing on culturally specific care for each individual patient. Cultural care preservation or maintenance is nursing care that helps patients retain their cultural beliefs and practices in regards to their health care. Cultural care accommodation or negotiation is nursing care that assists patients in adapting and accommodating their cultural beliefs and values to benefit their health. And cultural care repatterning or restructuring is nursing care that combines preservation and negotiation of health practices to respect the patient's culture while also adapting to enhance their outcomes. I developed my sunrise model, which can be seen on the right, as a part of my transcultural nursing theory. This model should be used by nurses to help individualize patient care by assessing their cultural needs. Those needs include technological, religious and philosophical, kinship and social, cultural values and beliefs, political and legal, economic, and educational factors. All of those should be taken into consideration while providing patient care. My type of theory would be considered a mid-range theory. According to Kershaw, mid-range theories are more concrete and less abstract, address specific phenomena within the nursing profession, have a measurable and definable relationship between concepts, and are able to be applied to practice. My transcultural nursing theory addresses the concrete and specific issue of generalizing patient care to their disease and not taking their cultural beliefs and values into consideration when providing them care. My cultural theory also defines culture as values and beliefs that guide the way an individual or group thinks, acts, and lives, and cultural care are aspects of culture that influence an individual or group to improve their health or deal with illness. Combining both cultural practices with traditional Western medicine will increase patient outcomes and compliance. One may measure the effectiveness of utilizing culture within patient care by assessing their outcomes along with assessing the patient's compliance with following the care model, such as taking prescribed medications, going to follow-up appointments, or withholding from participating in traditional treatment modalities specific to their culture that may harm them. My three caring modules and sunrise model help nurses to apply my theory to their practice and that they know what cultural factors to assess for and how to preserve, accommodate, and restructure their patients' care in order to retain their culture as well as provide them with adequate Western medical treatment in order to enhance their healing process and improve their quality of life. How transcultural nursing meets key terms of a theory. There are four key terms of a theory: client, environment, health, and nursing, all of which are met through the transcultural nursing theory. Client. In transcultural nursing, the client is viewed as independent from their disease and is treated individually based on traditional healthcare modalities in combination with their cultural beliefs. Environment. I do not describe one particular environment since my theory focuses on differentiation of cultures and therefore differentiation of environments. Thus, environment can be described as culture. Culture refers to learned, shared, and transmitted values, beliefs, norms, and lifeways to a specific individual or group that guides their thinking, decisions, actions, and patterned ways of living. Health. In transcultural nursing, health is culturally defined, not defined by myself. Nursing. The nurse must be flexible and open-minded in the transcultural theory in order to individualize their care to fit the cultural needs of their patients. They should provide adequate care using traditional Western medicine while also trying their best to incorporate therapies and practices observed by the patient's culture as long as it will not negatively affect their health. One research study that used my transcultural nursing theory as its foundation was of a Bedouin woman from Man with suspected breast cancer that went to a hospital in Amman because their hospital was more advanced than the one in Man. The nurses in the Amman hospital did not know much about the Bedouin culture, only that they are very modest and conservative people who do not believe in modern technology, cars, or electricity. They were also under the assumption that women were not allowed to speak much unless they were in the privacy of their own home. Once the Bedouin woman and her family arrived at the hospital, the nurses learned that they spoke in a different dialect and that the dress was also very important to their culture. Women were to wear a black dress with a scarf-like head covering known as an asaba, which is pictured in the right upper corner. As well, women were not to be cared for by males, and extended family was of great importance to the Bedouins. Of other significance was that the woman did not have any health insurance, but her tribe agreed to pitch in to help cover her medical costs. The nurses at the hospital used my sunrise model to note factors of the Bedouin culture that needed to be taken into consideration to provide adequate care for the woman. One of those factors was technology. Since her culture did not believe in modern technology, the family had to adapt in order to run tests to confirm the woman's diagnosis of breast cancer, and once that diagnosis was confirmed, to treat her with modern technology, with chemotherapy and radiation. Another factor was religion. Bedouins practice Islam, and in the article it was noted that the family believed the woman would be cured by God, proving religion and faith plays a large factor in their life. Kinship was also a factor. Bedouins are very family-oriented, and especially extended family, and the patient was noted to have had 50 visitors from her tribe. Economics was also found to be a factor since the woman did not have health insurance. However, since she came from such a family-oriented tribe, they all agreed to pitch in to cover her medical costs. Lastly, cultural values were very significant, which were seen in the way she dressed and by her desire to be cared for by a female nurse. After determining cultural factors, the nurses then used my transcultural theory to provide the best care possible to the patient by utilizing cultural care preservation or maintenance, cultural care accommodation or negotiation, and cultural care restructuring. They maintained her culture by allowing her entire tribe to visit her and providing her with a female nurse. They accommodated her by having her change into a hospital gown, but then allowed her to wear her asaba on top of it. And then they restructured their culture by having them adapt to using modern technology to allow the patient to be adequately diagnosed and treated. Lastly, I am going to discuss a case study in which I used my transcultural nursing theory as a basis to provide care. The case study consisted of an 8-year-old boy from Egypt that was hospitalized due to cutaneous leishmaniasis, a parasitic skin condition that's caused by sandflies, and a secondary bacterial infection. Using my sunrise model, I assessed 4 of the 7 domains to be applicable in the child's cultural needs: educational factors, religious factors, kinship and social factors, and cultural values and beliefs. In this case, educational factors refers to the child and his family's lack of knowledge of the English language. They were able to speak and comprehend some English, however their primary language was Arabic. Religion was also a factor. The child and his family were Muslim, and because of that were not able to eat certain foods such as pork, which included medications containing gelatin, such as certain antibiotics. Another religious factor for those of Muslim faith is that they must pray 5 times a day, and they practice Ramadan, the month of fasting from sunrise to sunset, though it is not typically observed by children or the very ill. Kinship and social factors were also of concern. Egyptians are patriarchal and view the father or other older males in the family as a decision maker in regards to health care, and for that reason oftentimes they are the ones to answer questions, even if directed towards the ill. Some cultural values and beliefs that were a factor were Egyptians sometimes will nod to convey that they are listening, which nurses and physicians sometimes take as a sign of understanding. Egyptians are also very quiet and hesitant to ask for clarification. After acknowledging the cultural factors that may interfere with providing adequate care, myself and the boy's doctor utilized my transcultural nursing theory to modify his care. We used cultural care preservation and maintenance, and that the physician wrote a prescription for an antibiotic that did not contain gelatin to allow the child to abide by his religious culture. As well, I learned to direct my questions or statements to the boy's father and uncle who took turns staying with the boy as they are viewed as the decision makers in their culture. We also structured our care as not to interrupt the child and his family during times of prayer, and it was not Ramadan, so that was not a factor. We used cultural care accommodation by offering the family the use of the translator services to allow them to speak in their native language of Arabic. We also provided written discharge instructions both in English and Arabic. Finally, we use cultural care repatterning or restructuring by encouraging the family to express their concerns and explain the importance of them understanding the treatment and medication in order to safely and effectively treat the illness. Lastly are just my references for this project.